Thank you very much, David, for that most kind introduction. It sounded a bit like an obituary, but I guess that was me. It's a real honour, though, to be here, to be invited as the Levitt lecturer here, following in the footsteps of many grand people. And I hope that we'll have a fine time together. So today, what I want to talk about is the great potential of primary care to help people with serious illnesses live and die well. Palliative care for all. Because I believe that primary care is really well placed to take forward palliative care. I work as a GP, as David is, as a family physician, and I've enjoyed that very much. I've always tried to address inequalities. I went out to Africa to help people there because there were a lot of physical problems. Came back to the UK, and a big issue there was that people with non-cancer serious illnesses weren't helped so much. They were having a much rougher time than people with cancer. So then that's really what got me into palliative care. I thought, how can we better help people with serious illnesses? So we started a campaign in the BMJ actually about that to highlight the inequalities of care in those two groups. So that's something about that. So I'll move on now, and feel free to say yes or no at any time. I have one or two videos and stuff we could show at the end of this time, but we can go from there. So primary care and palliative, we have a lot in common, haven't we? They're both about 50 years old. I know this Levitt lecture series started 40 years ago, I think was when it started, so it's about there. Both of us, we claim to be, used to be called patient-centered, but now it's person-centered, isn't it? We're both the same. We both value continuity of care and planning, and we think good end-of-life care can and is provided by primary health care teams. But to critique it a bit, palliative care sadly has retreated to late-stage cancer in the minds of the press, patients, and even professionals. You know, many people associate palliative care with dying of cancer in the end of life. And so that is not how palliative care was defined at the beginning. Palliative care was to help people live well. The word death does not appear in the definition of palliative care at all. And I'm saying there's a great role for a palliative care approach in primary care. And that's the case that I'm going to just be chatting about now. Now, I don't know if you've seen that slide before. That's the mortality rate for being human. I've heard that people don't die in America, actually. You don't do die. But that's the data. And next year's data is going to be the same. Despite rescue helicopters and all that type of stuff, we all get born and we all die. Yeah? Death is a sexually transmitted condition, universally fatal. And palliative care, people face up to that. Primary care, starting to do. And I was chatting with a geriatrician colleague as well. Geriatricians, I would critique them in Scotland. People get frail, they don't die. And so I don't know, but I'll probably be slagged after about that. But the point is that about 70% of people would benefit from this approach of palliative care, of listening to people, being person-centered and planning ahead. But most miss out. And because they miss out, there is suffering that they need not have. And that's why promoting health at the end of life, health promotion is very relevant to dying. Public health doctors actually usually use death as I say, if you don't do this, you'll die. But in fact, there's a lot of preventable distress around dying that could be prevented. So there's an interesting take we might come to later about that. So actually, I met David there at this International Primary Care Network. So I'm going to mention one or two things just to show you that primary palliative care, now we define that actually in Scotland as palliative care in the primary care. My colleague Amy Abernethy here defines it, and quite a few people in the States define it as generalist palliative care. I believe in both. Okay, I believe all hospital doctors should also not abandon patients when they're seriously ill, but continue with them. But this is a group, and I might even invite you to join it. So we started in Australia when I was out for a sabbatical there with Jeff Mitchell. And then once a year, we've been meeting annually since then, sometimes in a primary care conference. And we're in Ottawa, we were at a NAPCRAG, was it? when we met, sometimes a palliative care conference, and in primary care we say, remember palliative care, how about let's take this forward? And in the palliative care one, we're talking about the benefit of palliative care. And palliative care, I'm a member of the Association of Palliative Medicine of the UK, but I'm not allowed to be a full member because I'm just a family physician. So there are some issues, I don't know how it is in the States here, but there's some issues about a specialty becoming a specialty and just honing in itself on it. But anyway, here's a group, and the role of this group is just to advocate for palliative care in the community. A group of friends who are trying to work together with this vision, supporting and networking and encouraging research together. And we've written many advisory pieces on that. And if you'd like to join, the website is ippcn.org. There's a group, David's on the committee just now. I recently left the committee, but it's a great group of friends. And for instance, say you're wondering, who can I get to referee this paper? You'll see a list of people who might then understand who we're around. So that's an organization, and it's going on ahead. And it can be used. It has a great position. Other organizations, the WONCA. Do you know what WONCA, the World Organized, this GP one? Some of you go to these conferences. Have you ever been to them? I think, Larry, you're going to one soon. That's another area. So there's a special interest group in cancer and palliative care there, which can be another place for going and meeting. And recently, when the WHO wanted advice on palliative care, they will come to the World Organization group, and we can give advice from there, as well as our international group. So these are other groups as well worth visiting. Also in Europe, I used to work in Africa a lot. I still do, and I have a real vision for developing things there. And there's 54 countries in Africa, and about the same number in Europe. But there is a European Association of Palliative Care now has a primary care reference group and a toolkit where there's one GP, one family doctor from each country in Europe come together at their conferences to see how we can promote palliative care in the community, in the country, or in the region they're all at. And you can see a lot of the family doctors got together a few years ago and produced a toolkit. So these are the doctors coming together to actually work out how we could actually help each other develop primary palliative care in each of these countries. And we produced a toolkit which has now been interpreted, translated into a number of countries to try to encourage this concept of palliative care in the community. And it's the public health idea of palliative care is that you need an appropriate policy in a country for it to be working. You need a system to be working. You need training there. And you need morphine availability. That's especially important in Africa. And that is the public health way of trying to promote palliative care. And in these countries, we actually highlight what policies are there in different countries that we could help each other, learning from a different country, and how the various educational things are going. And so the WHO, although they've defined palliative care for many years, for the first time ever had a resolution about palliative care, that all countries should have palliative care integrated in their NCD or non-communicable disease managements. And it particularly singles out palliative care as the community as an area where this could happen. And they have to report on progress. So we've now actually got an agenda to work to. And that was the document that our groups helped WHO produce in 2016, saying this is how to integrate palliative care into disease management. And then further to that, just last month, there's a WHO publication here. I would commend it to you. Integrating palliative care into primary health care. And this guides policymakers and implementation and different countries how this could be done. So all that just shows you that work is being done, maybe to take primary care forward. Primary care is a place where palliative care can go forward. So that was just a little introduction to mention those points. And there's an essential package of palliative care for primary health care, especially useful in some countries. But the idea is that palliative care added to any health system can improve the health system. NCDs, that's non-communicable diseases management, must have palliative care attached to it, integrated throughout, and that is now a WHO mandate. So now what I'm going to go on now to talk about, okay, that's a bit of background, but palliative care, I'm saying that there are 5 key challenges can be met in primary care. So palliative care for all. So I just want you to remember these 5 things. In primary care, we can go forward with palliative care, number 1, for all illnesses. There's 5 alls here, okay? I have 5 fingers here. All illnesses. The second all we talk about is all times, because in primary care, we see patients early on, so we can start palliative care whenever it may be suitable. So all diseases can be helped in primary care, all times, all dimensions of need, because we are holistic, are we not? So we're there to help people in different dimensions of need. All settings, and in primary care, we're helping people in all settings, and all nations there. So that's the 5. The great potential at primary care, and overseas, in all countries, primary care, it can help. Of course, in some countries where primary care physicians work in teams, it may be easier to render primary palliative care, and therefore we try to work out how some teams, like in Belgium, for instance, family physicians work in isolation 1 or 2, whereas in other countries like UK, we're in larger groups. So there's various background factors that we can't alter. But let me just illustrate how actually we can take forward the great potential that we have as primary care people. So there's the trajectory slides of it we've been doing. That we know that we have 20 deaths a year per GP there, 5 from cancer, 5 acute deaths, typically cancer, 6 from organ failure, and we're talking about heart, liver, lungs, kidney, and frailty. And those sort of illness trajectories of the end of life are now sort of being accepted to show that dying isn't just the same, it can be different. And we've done various studies in research. There's a study in the BMJ a few years ago about COPD, because I knew that people had, as primary care people, that people have a lot of distress and long times with the COPD. So we compared them dying with people, a cohort of cancer, and we saw there was a great unmet need there as well. We've looked at heart failure, done a number of studies there, and also there we know that primary care, the research we did in primary care shows that there's a great unmet need, and that what's up for us now is to try to work out how to actually help such people. And this future care planning is a step that we could probably take it forward. Also, as we research, and as you research, if you've researched with hospital specialists together, it allows us to actually not influence them, but take it forward. Initially, the specialists in hospitals help identify patients for us, which was great. But that was all they did. But now we always make sure that as we do our research, they're fully together with the different people, so that we can actually work out how the hospital doctors could actually develop palliative care for their speciality, if you want, as well as a more general approach. There's liver disease. That's less been studied, but in Glasgow, more people are going to be dying of liver disease next year than heart failure. It's the alcohol problem, I'm afraid. And this is a very, very difficult situation there. That's the illness in Scotland that dies mostly in hospital. 7% of people with liver failure die there. So we're trying to work out how better, and they have a lot of needs. We've studied, using our serial longitudinal interview data, again, we've looked at people with frailty, trying to look at their various dimensions of need. But these are all people. I'm trying to illustrate that people from all illnesses actually can be supported. And we as GPs, we can say palliative care for all by need rather than diagnosis. Is that point made? You think, yeah? Yep. Can we try to help most people with the chronic illness in primary care? Yeah. So the first all is all diseases. The next one is all times. And the question is, when do we shift gear to add in, if you want, a palliative care approach? Because it's not, in the old days, you were either curative or palliative, but nowadays, at a diagnosis of a life-threatening illness, You don't have to be dying soon, but a diagnosis of a life-threatening illness, that's the definition that WHO uses, which is start a palliative care approach or supportive and palliative care approach in parallel with the curative care. It's not one or the other, it's both and. So the issue is we can do it at all times, and the question is, of course, when do you start? And so in this picture, I'm showing an typical organ failure pathway. That people come to a certain stage at the beginning of that, which is deteriorating health, where these admissions to hospital become a little bit more common. And so it's in the early stage that it is good to be identifying someone for palliative care. We'll come back in a minute to work out how to do it. And later on, just before someone's dying, there's a later palliative care stage that's also good to look at. So there are various tools or instruments, and the gold standards framework is a framework of care common in England, where there is a tool, prognostic indicator guide, which can then identify people for palliative care. We have another one, I'll go into more detail, called the Supportive and Palliative Care Indicator Tool, which we've developed in Edinburgh. And again, there's a website there which could be looked at if you're interested in this. So it's a supportive and palliative care. And now it is being used by those number of partners in a lot of countries. So it's being used quite a bit. There's more, and there's an app in it as well. So we published this in the BMJ in 2010, the validation of this tool. And as we can see, it's being used quite extensively. And how does it work? Well, that's what we did. And the first thing is there are general indicators of deteriorating physical or mental health. So it identifies people who are at risk of deteriorating. And if they're doing that, you think, that possibly could be a person be identified. And then you check over various clinical issues that they may be having there. It's reasonably accessible, and it supports identification in all settings. So we started with a tool that could be used. There's information on the website how you might use it in family practice, how you might use it in hospital, how it could be used in care homes. And the idea, it triggers a thought, because the idea is to try to identify a certain time when it's useful to add on this palliative care at risk of deteriorating. It doesn't include the surprise question itself. It used to, but we've taken that out because we found that one slightly there were too many people being identified for that stage, and hospital doctors didn't like it as well. So it looks a bit like that. That's too small to really talk about, but you can see the top bit is about general indicators of deteriorating health, and that's the top line. And then there's more clinical ones, and then the bottom box on the right is about review the current care and care planning. So the idea, it helps identify people, and then we go forward and assess and plan. Identification, assessment, and plan are the key constructs in palliative care there. So we also have done one called Aspect for All, and that's a tool that family carers or the general public, or maybe people working as support staff in a care home could use to actually identify people for this approach as well in acceptable language. And I mentioned that the surprise question, of most. Hands up if you know about the surprise question. Most people, so some people don't, but the idea is that if David, for instance, is 85 and he's had heart failure, been into hospital 4 or 5 times, yeah, would you be surprised if he died in the next year? Yeah, you don't have to expect him to die in 6 months, okay? But if you wouldn't be surprised, well, maybe he might die, and therefore, if you're a good clinician, you should maybe make a plan to go ahead. So that surprise question Joanne Lynn started with, it can be helpful to trigger. It's not really about prognosis, as I use sick enough to die more is how we meant to do it. But that surprise question could be used. The idea is there comes a time when we have to consider this approach. Yep.
So the SPIT, what percentage of patients in general practice will be identified in the SPIT?
About 1%. About 1%. Yeah. About a year out on average. Yeah. And you can see here that a good question, with cancer people who die, 88% could have been identified by the SPECT. And with chronic illness, 80, and frailty dementia, 88. So it has the potential to identify most people who are dying. But it depends. If you start, the SPECT can be used to, you just maybe add, it doesn't mean you have to look for your 1%. In the UK, there was doctors find their 1% of people so they can die. You know, that was bad press. The Daily Mail took that one up, so we don't want to go there. But we're trying to find people in their last phase of life. So we're not just talking the last weeks or days, and as most people die around 80 or 90, that equates to about 1%. Is it wrong to identify someone for palliative care and they live for ages? Not really, because it's not an either-or, it's an addition. Palliative care gets to places, okay, that other types of care can't get to. There's an advert for beer in the UK about doing that. That's the idea of palliative care, it can do that. And there's a Spanish validation and adaptation to it there. It can be used in hospital medicine. The SPECT would identify more than 1%, because we know that about a third of people admitted to hospital will be dead within a year. So that would be the indicative, if we want, prevalence of dying in the hospital there. And there's our German group who've gone ahead and used one for Denmark. I'm not at all precious about the SPECT. The message is we have to think about a time when we start this approach so that people don't die too soon, okay? Die without thinking about how they could be helped. That's the real point about there. And there's one now that we're using in low-income settings, that is, so things like drug-resistant TB would be an example of a common condition, but not so much. So we adjust the content of it for that. And here's what we can do. In primary care, in GP, we can do computer searching for palliative care needs. So we've developed a computer search with some software developers using the basis of the SPECT, and whatever parts of the SPECT are actually computerized, because acute heart failure admission isn't normally computerized in primary care. It's not given a read code, but we have done a search using various categories of the SPECT there. And we've shown that GP practices can use searching to generate a list of people. And this search identifies about 1% of people. So I asked my computer, please find people who are not already getting palliative care, who might have, for instance, liver failure and heart failure. It's really good at multimorbidity. So by doing that type of thing, that's one way of getting, and some doctors, some GPs find that useful. You get a list. What do you do? I'm too busy. So that if you've got a list, you could flag up all these people for assessment at our next meeting, for instance. Or you could just ask people, well, that one's obviously sort of needing help. Why just we don't to that person? So it's just another way. They talk about the doctor's nose. Have you heard of that phrase? You know, I think this person, you know, the intuition, clinical intuition. But people work in different ways. So there's clinical intuition, but this is another way that can be used. I think I maybe got a little information about it. Yeah, so that's the search algorithms that we were using. And it was really good for getting people with or identifying people with combined codes. Heart failure and COPD like that. Here's a slide now about identifying people in Scotland for a thing called anticipatory care. Because in Scotland, we decided, we were talking about advanced care planning, we decided we'll do anticipatory care. So anticipatory care is basically early palliative care. And the system is such that we can actually encourage, and all family physicians want to share a patient's record if they're serious without of hours. So when we are with a patient, we can say to them, do you mind, say they've come back from hospital having had admission, do you mind me sharing the information with the hospital? Now patients would say, I thought you would do that anyway, so no one objects with that. But then that allows us to generate a thing called a key information summary. a key information summary. I think I'll go ahead and maybe explain what that is. So it's a new IT development pioneering a shared medical record between professionals. It allows selected parts of the electronic record to be shared with other parts of the NHS using a template within our computers. So when the patient says, yes, that's fine, I would then actually click a box for a key information summary. Data that I've been talking about with the patient would be extracted automatically onto this key information summary and sent to the hospital and out of hours twice a day. So that's just a system that allows care, and we don't call it palliative care, we just call that anticipatory care. And that allows us to start palliative care, I wouldn't say covertly, but helps us to talk to that person and to plan ahead. And the fact it's in the same system is very helpful. It works for all the 3 GP systems that run in the UK. And it could be adapted. But the idea of actually having a reason, it gives a GP, a family doctor, a reason for going ahead and identifying someone for palliative care, anticipatory care, because that's going to benefit the patient, and the patient would like to do it. So that's my thought about anticipatory care. It's a new word we used. But our research, we did a study 3 years ago showing that actually anticipatory care starts earlier and reaches more people by their death by these different illness trajectories. If we didn't call it that, we're trying to actually inhabit that white area so that we know people are getting some support. So it seems to be working well, and most people now die with anticipatory care plan in place, communicated through the key information summary with the hospital, and there's a record held by people at home that they chat with their carers about, and they fill that one up, and they're thinking about the future. And that contains things: where would you like to be cared for? If you got very ill, where might you like to die? Do you have any special medications at home? Things like that. And we can see that the key information summary is progressively completed. So it's an iterative point from when it was started towards the end. And now we're trying to convince hospital people. So if someone is admitted, check if there's a key information summary there, because that will be a way in to maybe talking realistically with people. So that's something about the key information summary and anticipatory care going forward. Anything about that before I move on to, so the idea is, when do you start? And we've called it anticipatory care. I know in Canada now you sometimes get chairs of supportive care. And there's an awful lot in a name in many disciplines. And we're not trying to hide things from people, but if you do something and it seems to work, and I've spoken with our politicians in Scotland, they say, just go ahead and do this. Because there was a record, I'm not on the palliative care register. You know, the palliative consultation can be so difficult to run and hold, can't it? You know, it'll take a long time. This is easy to get started and run with, and it seems to work. So we're going along that way. But that would be good to discuss. Okay, so let's go on to this third dimension of all. We've had all diseases, all times, all dimensions now, because we are all capable, I'm sure, of looking after these dimensions of need, whether we are general practitioners or palliative care people. So what we showed, dying is a 4-dimensional activity, yeah? I think folk would agree with that. If you were a minister, you might think spiritual dimension is the most important, yeah? If you're a social worker, you would say dying is actually basically social. So, and if you ask someone what the main problem is, it could be in any of these conditions. So what we actually looked at, we interviewed many people in their last months of life, and we analysed the interviews longitudinally and then cross-sectionally over some number of times. And so we have a lot of information of the experience of people towards the end of life. So I just want to show actually the findings that we got here. So there's a typical physical decline in someone with the acute cancer trajectory. And listening to the people at interviews, you can see there's a quotation. His old friends won't even take a cup of tea with me. Now I've got cancer. So what we're seeing and suggesting, there's a social decline at the same time as the physical decline. Do you get me okay with that? Does that make sense? It makes a bit of sense. So we're trying to say death isn't just physical, there's a social dimension going on there. There's also a social decline in the family carers. So what would be happening in the other two dimensions of need? Do you think they all go down together like that? What do you think would happen? No? Someone's saying no. Anyone want to shout out?
I think the spiritual would increase.
Spiritual would get worse.
Increase.
Yeah.
They think about it more.
Right. So, yeah. And it may cause distress. Yeah. That's right. Yeah. Mm-hmm. So here's, and they could well do. So here's what actually we found bringing them together. So here is you want the cancer trajectory, and we found at diagnosis, when people are physically, socially quite well, you're told, you've got cancer. That's quite worrying. Yep, I got lung cancer 4 years ago, and I worried a wee bit about that. There's anxiety, and even why have I got it? So at diagnosis of cancer, you might expect some distress in those areas. You with me? Yep. And as a GP, I also know that they'll go to the hospital, they'll feel better, getting treatment, they'll come home. And it was like a black hole. So I could predict that coming back from hospital, and again at recurrence, if it happens, and in terminal decline, there are times when you would expect, so there's a typical pattern of this dynamic needs in these dimensions going on around there, which has implications for advanced care planning, of course, or care planning. So that's what seems to be happening there, and how you could help. So if someone out of hours so the implications of that is that at diagnosis, the person may well need some support with the anxiety or possibly existential issues. Would we call that palliative care? Not sure. But that approach, now I wouldn't call it to the patients, but the idea is that early on, it might be a time for it. So that's about that. So looking at trajectories of people with the organ failure trajectory, we found the physical one is the green, I think, up there. But at the same time, when people are bad well, often they have distress at the same time. There may even be a bigger social problem. So we can predict that when someone's possibly going into hospital, there are other aspects or dimensions of need that are at play just now. And so care planning, if we're trying to give anticipatory care to someone with heart failure, the idea, anticipatory care is talking about what might happen to them. What you're worried about? What can we do to maybe prevent you having distress? So we can be preparing them to deal with anxieties up ahead. The spiritual one we found harder to actually plot. In this, it was more dependent on various services they're getting. But we're just saying there's lots of different dimensions. So if you're having to see someone out of calls urgently, there are many aspects that we should think of, not just the physical. And there's the trajectories we found in people with frail older people. So the physical ones at the bottom, but we found quite often a few months or even a year out before they would die, there was distress that could be seen in these other patterns of need. Maybe there was anxiety. I'm worried about going to a care home, or I'm worried about the distress. I'm worried about the responsibilities my supporters might have just now, or even worried about getting dementia. So that these other worries, so good palliative care, anticipatory care for such people, so dealing with their worries at that point of time, which could be those three things rather than dying. There are a lot of things worse could happen to me than dying, doctor, And so good anticipatory care is actually dealing with their needs. Mm-hmm. Any questions about that graph? Are we okay with that one? Yeah. And there's a similar graph of family carers with the cancer one there. And we found by interviewing these carers again in parallel that they also, when your relative is having cancer or whatever, there's a helter-skelter in the other dimensions of the family carer. So physically also a slight decline, but they're going through the same sort of process. So again, we'd expect that. So that has implications if we're helping folk at home and their carers to let them know that they're also going there. Because when someone's dying, they will be dying physically, but we would try to optimize the other dimensions, wouldn't we? Yeah? A peaceful death. Well done there. So the point of these trajectories is just to say, and so when we published those last year, I was trying to promote that we should be thinking about these different trajectories. And that was a podcast, and we put out a video at the same time. It's a new tactic. An amateur video. I had a geriatrician staying with me for a year who's a great expert at videos, and we did one there that showed that can be used to explain the rationale for early palliative care according to different illnesses. I'll just go on to all settings. I've got this picked again. It's just to say that there again, people have to be identified in all settings. I was going to mention about care homes is an issue, a current issue in Scotland where we can't get reliably good care. Are care homes a big issue in the States, would you say? A bit? The idea is there's not so much, like as a GP, I'm sometimes asked, do you know a good care home for my mum? Whereas if there's someone pregnant, they wouldn't say, do you know a good antenatal place I can go to? Because they're expected to be reliably good. So there's a big issue with the care homes in the UK just now. So we've got a vision for a teaching and research-based care home. I'm just flying up this one because hospice movement started 45 years ago and brought a sea change into the public perception of dying and the care, a focus on it. Now, there has not been a teaching home centre of excellence with research and education based in it that has actually worked, and we reckon this can actually bring a sea change to that. The professional perception of care homes. We've been scoping the international literature on this, had a visioning day. We've visited various places. There are such care homes in Norway, down at 4 in the spine of Norway. 60% people die at care homes in some countries. So it depends a lot on the services that we offer. And we're looking at the feasibility of that. The Minister of Health in Scotland has agreed this is a big demographic challenge, and we're hoping to go ahead and do this. And we've done a feasibility study. The idea is that we will have attachments to the care home. So medical students would go there and see excellence in care in care home medicine. Nurses will go there. There'll be a nursery next to it, so there'll be intergenerational dialogue and stuff. And we're trying to press ahead with that. We're negotiating actually with a big pension fund provider for £50 million, and we're going to build one for 15 million, and the other funding we'll be doing to develop other aspects of care for people with advanced illness. But again, I guess it's the inequalities of care. This is the group of people, the frail older people who are having a pretty bad time. Partly because I may be that stage in 15 years' time, and I want things sorted out. But there's a real issue in that. Okay, so that's the idea of palliative care should be there in all settings, and in care homes currently just now, not many are supported by palliative care organisations, although some of the newer ones are sending in maybe a specialist palliative care nurse from time to time. And the current family doctors aren't supported much to give care there. Okay, just a word about all nations then. So primary care has a great place to play in developing palliative care in various African countries, because often there is actually no hospice and no other access to care there. And it can certainly support there. I'll mention a study we did which highlights national inequalities. We compared people dying in Kenya and dying in Scotland. So in Scotland, I had people with lung cancer and being interviewed, and we understand their main reason. We're asking, what's your main issue in dying just now? Now, we had a cohort of people with common cancers in rural Kenya. They were slightly different, esophageal and liver, and we asked them what their main problem is. Tēnā yaku ne kuri nene no riko. So we're trying to ask them, what's the biggest problem, you know? And really we were trying to think, will they say physical, psychological, social, or spiritual? Yep. So dying in Kenya, what do you think was the big issue that people had? Can you guess? There were some social problems, but in fact, it was more physical. It was the pain. You know, there wasn't money for that. The psychological, people appeared to be slightly less anxious, and they got support from their neighbours and visitors. The Women's Guild might visit them and help them there. So they didn't have access to opioids. So the main issue, if you want, in the Kenyan concept was actually, so that was the nurse there interviewing someone here with esophageal cancer dying in rural Africa. So the main issue in Kenya, analysing the interviews, was the physical suffering, especially the pain. I've no money for painkillers, for instance, and there wasn't access to morphine to the great majority of people, unaffordable. There was acceptance quite often, rather than the anger which was often expressed in the group in Edinburgh. And the community support was accepted very much there, and many people were comforted by their religion, which was more manifest in that context than Scotland, which is rather secular nowadays. So you can see, comparing that with the main problems people had in Scotland, interviewing people there with lung cancer, the issue was generally just about themselves. You know, why have I got this? Yeah, rather than a physical, specifically physical. Maybe because there is symptom control that appears to work. But there was a contrast in the dimensions of need that was happening here. Just keeping things to myself. And the spiritual needs were evident but unmet in Edinburgh, but the people were comforted. So I'm contrasting these three dimensions because in Africa, there's only these 3 or 4 countries where they're approaching availability of morphine just now in rural areas. There's only, because that's a big issue. There aren't enough doctors, so it's about training nurses to prescribe. And only Uganda is the only country where laws have been changed, so nurses can routinely prescribe morphine. But I mentioned keeping Africa up, because I think what I've been saying there is that we can actually learn quite a lot from Africa. Because in Africa, the community is more involved there in their own support and care. Death is more in their face. People die there, and people get a lot of support. So when we go out and try to support people on the physical side, that's good. But we mustn't stop the excellent care, other support that they're getting there. And we should learn how we should be able to promote a community support at the end of life there. We could talk about community health promoting palliative care, how communities can be more involved and should be more involved. And there's a paper showing how integrated palliative care is now actually being documented in various European countries. That's Xavier Gomez. That's a quake. That's me out in Mongolia. Mongolia is a poorish country, but it does very well in palliative care due to a visionary general practitioner, the lady on my right there. They are doing very well there. Other countries, Brazil, time for palliative care. Our international group supports people to say, how can we actually support palliative, helping them write, for instance, in the community. So Santiago, David knows Santiago is a GP like one of us who's out there, and he is bringing this approach into the large primary care teams that function in Brazil just now, because the great opportunity, because primary care is getting so strong there just now. So I'm just coming up to the end just now. There are many resources we've created to actually try to encourage people to in primary care to identify. But I mentioned the 5 different carings for all, so I'd just like to come back to that. Primary care, we're uniquely placed to be able to support people All people with serious illnesses, not just cancer. At all times, earlier, not just late. It has to be all. The third all is all dimensions of need. We should be able to do that. Can we do it? Is it just good general practice? Is it just good geriatrics? It's an approach I think we can do it, and all settings, and we can't neglect, and the current bad setting, as I've highlighted, is the care home just now. Half of care homes in the UK have nurses in them. Most actually do not have. And so there could be an implication. My family medicine colleagues say, it's like a hospice, these care homes nowadays. People go into a care home. Most die within a year as well there. I would say everyone in a care home is there to get support in their last phase of life. They should get anticipatory care. And that's why they could automatically go ahead and get this early palliative care approach. I think I'll finish. There are other resources, and we have created some videos because we try to communicate these messages in different ways, and with videos that can be used to support and explain to family doctors and teams, how we could go ahead with anticipatory care or whatever. So I think I'll leave it like that just now. Thank you.